Thank you, sir, and good afternoon from the Division of Trauma Surgery and Critical Care. I extend my greetings to all the faculty members and to the residents. Today, we are presenting a very unique or I would say interesting case, which was referred to us from AIIMS Rishikesh. And he came with an injury which often do not make it to the hospital. Majority of these patients, they die at scene only. But this patient, fortunately, was referred to us in time, and with timely intervention and with a very prompt and multi-specialty approach, we were able to salvage this patient and was able to discharge him to home. So the case will be presented by Dr. Mohit and Dr. Vikram from Trauma Surgery Division, Dr. Neha from Cardiology, Dr. Shivani, Dr. Neha from Cardiology, Dr. Shivani from Srividya from Srividya from CTVS, and Dr. Girish from Cardioradiology, and Shivani from Radiology. So, Dr. Mohit, please.
Thank you, ma'am. Very good afternoon to all of you. As trauma surgeons, we are regularly doing damage control surgeries, but here I present a unique case in which we managed an adolescent boy with a damage control stenting instead of damage control surgery. So our patient, he was a 15-year-old adolescent boy who had road traffic injury. The mechanism was two-wheeler versus two-wheeler. It happened on 12th of November at 9:30 p.m. The incident happened at Rishikesh, and it happened at a place called near Sai Ghat, which was approximately 26 minutes away from a level 1 trauma center. However, the patient reached almost 11 hours post trauma. Why so? Because the impact was so severe, there was death of the driver at the scene, and the pillion rider was thrown away. He went into nearby bushes. All the attention went on to the driver, and people actually missed that there is a pillion rider who got injured. It was recognized few hours later when a nearby auto was passing by and they heard that somebody is crying in pain in bushes. So that is how the patient reached AIM Rishikesh 11 hours post trauma. He was initially evaluated and managed at AIIMS Rishikesh, where he was diagnosed to have tension pneumothorax, for which right-sided intercostal drain was placed. And on further evaluation, he was detected to have grade 3 aortic injury in form of aneurysm of descending thoracic aorta. He was transferred to our center in view of some financial issues as patient could not afford stent and some administrative issues at their center. So it was an inter-facility informed transfer with patient coming in a private BLS ambulance. He was hemodynamically stable and was mainly referred for grade 3 aortic injury, which they couldn't manage at their place. So at arrival at our center, as we regularly triage the patient into red, yellow, and green, this patient had significant chest trauma and also abdominal trauma, so was immediately triaged red. And as per our SOPs, this patient was placed on an RBM with oxygen of 12 liters per minute. His respiratory rate was 18. He was not in respiratory distress. There was an ICD in situ with about 100 ml of sanguineous output in underwater sea. He was detected to have bradycardia with heart rate of 54. However, it was mentioned in the discharge summary that patient has been given anti-impulse therapy in form of beta blocker. So it was presumed that bradycardia could be related to the beta blocker therapy which this patient has received. Otherwise, he had full score GCS, was completely exposed, looked for other injuries. On adjuncts to primary survey, we can see a chest X-ray in which right-sided ICD is in situ and lung is expanded. Pelvic X-ray was essentially unremarkable. On assessing with ultrasonography, his E-fast was negative. On ample history, he has a significant ample history in terms of medication which he took. He has taken beta blockers, probably which led to bradycardia. And events leading to injury were so significant that we lost the driver at the site of injury. And he had lost that golden hour, which we so often speak in trauma. And he reached 11 hours after injury to the primary hospital where he landed. On head to toe examination, he had some facial abrasions. There was no significant extremity trauma or significant fractures. He was further evaluated with contrast enhanced CT scan of the complete torso. I would request Dr. Shivani to come and explain the findings.
Good afternoon, everyone. This is the axial post-contrast images of the chest. In this, we can see there is a large mediastinal hematoma. Along with that, there is a contour abnormality seen in this descending thoracic aorta, and there is left-sided hemothorax. The further images taken in the sagittal sections shows contour abnormality in the descending thoracic aorta in the form of aneurysmal dilatation, and this is also seen in this volume blended images. This was suggestive of a pseudoaneurysm of the descending thoracic aorta, which was distal to the origin of left subclavian artery, and it was suggestive of grade 3 aortic injury. The axial CT sections of the lung window show minimal right-sided pneumothorax with overlying subcutaneous emphysema and ICD seen in situ. The caudal sections in the post-contrast images taken which shows a laceration involving the segment 4A of the liver. Along with that, you can see the caudal extension of this peri-aortic hematoma, and there was mild hemoperitoneum. So to summarize the finding, there was a pseudoaneurysm involving descending thoracic aorta, which was around 2.5 cm distal to the origin, and there was a segment length of 3.4 cm. There was right-sided pneumothorax with lung contusion, left-sided pneumothorax, and there was grade 3 liver laceration with hemoperitoneum. The further discussion will be taken.
Thank you, Dr. Shivani. So we have as I mentioned, the patient had bradycardia. So we evaluated him further with a 12-lead ECG. And to our surprise, he had AV dissociation. The patient had complete heart block. So now we have got a 15-year-old adolescent boy at our hand who is 3 days post-injury. He is hemodynamically stable, has complete heart block, significant chest trauma with grade 3 aortic injury, and grade 3 liver injury. These were the burning issues at our hand. The patient has complete heart block, so he cannot mount tachycardia when required to maintain cardiac output. He has got a significant aortic injury, which definitely needs intervention. And because of his age, there was problem with excess site and the stent which were to be placed. Grade 3 liver injury was planned to be managed non-operatively, but anticoagulation was tricky in this case. So we urgently formulated a plan. We called for cardiology consult for congenital heart block. Aortic injury was to be managed with thoracic endovascular aneurysm repair, and liver injury was planned for non-operative management. Now, may I request my cardiology colleague to please come and explain what was done for the patient.
Thank you, Dr. Mohammed. So we have a patient who's a 15-year-old boy with complete heart block with narrow escape, with an escape rate varying as low as 45 per minute. So the possibilities that we had in mind were it could be a traumatic complete heart block. It could be a congenital complete heart block, which was detected incidentally at the time of this presentation. A much lower down possibility was that this was caused by beta blockers. However, beta blockers are unlikely to cause complete heart block in a patient without underlying conduction system disorders. So, considering the first two possibilities, we looked at the echo of the patient. It showed a normal LV function. There was no obvious RWMA, which rules out a significant vascular injury. There were no associated congenital structural heart defects. The troponin was also negative, which again favors that a myocardial injury was unlikely. So, with the possibility of congenital complete heart block, we proceeded to put the patient on a temporary pacemaker via right femoral 5 French venous access. The transvenous pacing lead was placed in the right ventricle. And so the ECG on the left showed the baseline ECG, and the ECG on the right shows the post-pacing ECG at a rate of around 60 per minute. We can see the pacemaker potentials preceding the white QRS complexes. So to complete the cardiac aspects, over the duration of hospital stay, the complete heart block with narrow escape persisted, which is again unlikely in the setting of a traumatic complete heart block, which is known to recover. There was an improvement in the rate to around 70 per minute. We also performed a 24-hour Holter with backup pacing, which showed a mean heart rate of around 55 per minute. The mean QTC was within normal limits at 399 milliseconds without any complex ventricular ectopy. So it was deemed that the patient does not require an urgent permanent pacemaker. So at the time of discharge, the temporary pacing wire was removed, and with a plan for an elective permanent pacemaker on OPD basis. I would like to call Dr. Mohit to continue the discussion further.
Thank you, Dr. Neil. So, as per our management plan, the congenital complete heart block was taken care of. Temporary pacemaker was in place. Now we had planned for TIVR for that patient. So some concerns for TIVR was it required multiple interdepartmental coordination with cardiology department, cardiothoracic and vascular surgery department, and interventional cardioradiology department. The patient was unaffording for the stent, which was costing around 4 to 5 lakh rupees. However, because of our experience of aortic injuries, in which we had handled more than 100 cases till now, the SOPs are in place, and we were able to sort exemption for this patient within 24 hours. And 3 stents were kept ready for deployment when it was deemed necessary. So this is day 1 of admission, 8 p.m. in the evening. Our patient is hemodynamically stable. Plan for TIVR is in place for coming morning. However, to our surprise in ICU, this is the next morning X-ray. This is what we see. This complete whiteout of left-sided chest with some shifting of mediastinum towards right. So patient has got massive hemothorax. What do we do now? Patient is hemodynamically stable. He doesn't have any respiratory compromise. His respiratory rate is 18. So ICD was kept on hold, and immediately consult of CTVS was taken, and patient was rushed to CTVS OT. We were running against time now because likely the grade 3 injury has now turned grade 4. So patient was immediately rushed to CTVS OT, where under controlled environment, he was intubated, all the lines were secured, OT was kept on hold, and it was discussed and planned that patient will be taken to CT for a ECG gated CCT, followed by which we will do a urgent TIVR for this patient. We are running against time, and it is a ticking time bomb with aneurysm, which is grade 3, it has turned to grade 4 injury. Patient was shifted to CT gantry with vitals of pulse rate of 90 and BP of 110 by 70. But again, the patient crashes inside the CT gantry once just the CT is over. Good thing is we were able to acquire the CT, but the patient has crashed with systolic BP dropping to 40. Again, a decision was taken with interdepartmental coordination, and patient was immediately rushed to DSA lab. We were able to take the patient to DSA lab because everything was well in place. Patient was already planned for TIVR. I would request my cardio-radio colleague, Dr. Girish, to please explain the procedure.
So good afternoon, everyone. So as there was progression of radiopacity in the left hemithorax, and also there was a high clinical suspicion of progression of aortic injury from grade 3 to grade 4, we went ahead with the gated CT with the intent of one, confirming the diagnosis of rupture, and second, to accurately plan the management, that is the TIVR. So this is the gated CT, where we can see the hyperdense pleural collection, that is the hemothorax, and also we can see the previously seen contour abnormality. Additionally, we can see there is a frank breach with the extravasation of the contrast, which is leading into this collection, that is the hemothorax. So the diagnosis of frank rupture was confirmed, and also in the same CT we assessed for the rest of the aorta and the access vessels. Here we can see the abdominal aorta, its branches, the common iliacs and the common femorals, which are the access vessels, were perfectly healthy and were of adequate caliber. So these are the representative MIP-CT images, where we can see the contour abnormality, and also we can see the rupture leading to the collection. So these are the VRT reconstruction images to just understand better understand the pathology. Here we can see this is the pseudoaneurysm, and this is the rupture, and this is the contrast extravasation leading to the hemothorax. So what happened was, until before CT, the patient was hemodynamically stable, and during the course of the CT, after the acquisition of the CT, the patient got destabilized. So the patient was immediately rushed to the DSA suite, and the preparation for TIVR were underway. And in the meantime, we sized our grafts. So this is the explanation for the sizing, where we can see the proximal landing zone. The diameter of the aorta at that point was average around 2.1 centimeter. So with a routine 10 to 15% oversizing, we will get proximal diameter of the stent graft as 24. And also with respect to technically successfully deploy the graft, in this particular case, there was need for coverage of the left subclavian artery, and the length of the graft that was required according to our calculation was around 12 centimeters. But as this was an emergent situation and the availability of graft, we had these two sizes available at that point, so we have to go ahead with the procedure. So the procedure was undertaken, and both right and left transfemoral axis were taken. So this is the procedural runs of the TVAR. This is the initial pigtail run, which was taken through the left transfemoral axis. And this one is the pre-deployment run, again taken through a pigtail. This is very much important because we have to plan the exact location of the point of deployment. So these are, we routinely take these runs. And this is the DSA run of the opening of the graft. And all this process was done very quickly, as there was the patient was actively extravasating and there was no time to be wasted. And this is the post-deployment run. Now, few technical aspects of this deployment. Here we can see our desired point of opening of the graft, that is the starting of the covered part, was distal to the left common carotid ostium, which we can see through these markers, which we are perfectly aligned, and also with respect to this specific graft, there are two markers, one is the 8 marker and is the 0 marker, which required to be aligned along the greater and lesser curvature respectively. So here we can see that it has been perfectly achieved. And more importantly, our main aim was to seal off the breach that was there. And we can see in these post-deployment runs, there are no active contrast extravasation. There is complete seal off of the breach. So this was the timeline of events which happened. As explained before, on shifting to the CT, the patient was hemodynamically stable, and during the acquisition, he got unstabilized. But we can see that post and deployment, his BP was stabilized again, and the heart rate was also improved. Post procedure, the runs of the DSA runs of the axis showed there are few filling defects with the abrupt cutoff of the common femoral artery, which were most likely due to thrombosis at the arteriotomy site. So the CTVS opinion was obtained, and I would like to invite CTVS colleague for further discussion.
So there was actually a thrombus present at the axis sites. We have done a thrombectomy. And because this was a young patient, we decided to do a vein patch repair of the femoral artery axis site. Following this, our inotrope requirement was quite less, and the patient was then shifted back to our ICU. And now our main management post TVAR is usually that we maintain a mean arterial pressure of around 80 to 90. So main issues are here, considering that this was a thoracic graft. We have to avoid any spinal cord ischemia, and we have to look for any signs of spinal cord ischemia. We maintain a higher mean arterial pressure. Another thing is the left subclavian was actually occluded in this case. We look for signs of any upper limb ischemia. And considering that we had done vein patch repair of the femoral artery axis site as well, we looked for any signs of lower limb ischemia. We had none of these events. The patient did quite well. Our vasopressor requirements came down. Of course, the massive left hemothorax was still there. The mediastinal shift was not causing any more hemodynamic instability. We were able to ventilate the patient quite well. So we decided to hold draining the left-sided hemothorax as well for the time being. We waited for 2 to 3 days. So considering that the patient was doing well till now, we transferred the patient back to our trauma surgery colleagues the next morning.
Thank you, Dr. Srividya. So as we can see, the patient in the morning, we saw an X-ray at 8 a.m. There was a massive hemothorax which was present. We immediately rushed the patient to CTVS OT, and within 4 hours, we were able to stabilize the patient with damage control stenting. And I would like to mention that a CT was acquired at around 11:20 a.m. and within 10 minutes we were able to shift the patient to DSA suite, and in another 10 to 15 minutes we were able to stent the patient. Subsequently, the patient was shifted to trauma center, and on day 3 of post-procedure day 3, patient had some respiratory difficulty, for which left-sided intercostal drainage was placed and gradual decompression was allowed. Patient drained approximately 1.6 liters of retained hemothorax over 24 hours, but still he had some retained hemothorax, for which he underwent video-assisted thoracoscopic surgery, which was uneventful. Retained hemothorax was drained, and post-procedures his lung expanded. So on discharge, we have a patient whose lung have expanded fully. He is fully ambulatory. There are no spinal cord complications, and he was discharged on day 15. Now I would request Dr. Vikram to please come and discuss the case. But I would like to mention the critical decisions which we took, which helped us probably was the experience with aortic injury. We had a system in place in which we can coordinate with all the departments and we can get exemption as early as within 24 hours. And obviously, damage control stenting, which we decided in this case, helped us save this patient.
Thank you, sir. I'll be continuing with the discussion part of the case. So, first issue which we had is the patient had complete heart block. So, as we know, the complete heart block is usually common in congenital cases, but this patient was an adolescent and also it was rarity in the trauma setting. So most commonly, usually if patient has complete heart block, they usually will be symptomatic with exertional dyspnea, syncope or pre-syncope. And the prevalence rate is around 2 in every 1 lakh patients, which has been shown in Japanese studies. And it has to be treated. Why? Because there is risk of sudden cardiac death. So as we know, as we can see here, there are many non-traumatic cases and trauma is also one of the rare possibility for complete heart block. As we can see in these case reports from 1999, there are few rare reports where complete heart block is possible post-trauma. So coming to the blunt thoracic aortic injury, which our patient had. So most commonly we encounter in RTA settings followed by fall from height. And unfortunately, 80% of the patients will die in the scene and less than 20% reaching us. The aortic isthmus is the most common point of injury. Before 1994, only management which we had was open surgeries. But post that, we were able to do endovascular repair. So as we can see, according to the classification, our case presented with grade 3 injury, which progressed to grade 4. So as we can see here, the open repair, which was clamp and sew technique, which was the method which was performed before 1994, had so many complications associated with it. That is ranging from spinal ischemia till the MI. Patients used to have many complications. As we can see in this paper, which reported around more than 2,500 cases, the overall mortality rate varied till 45% in ruptured aneurysm cases, and patients had complication rate varying till 50%. So with this paper, which has been published in 1994 in New England Journal of Medicine, was a revolutionary one, in which Dake et al. Proposed TEVAR in descending thoracic aortic aneurysm. So with that, TEVAR took over the open cases, and the paper which has been published in 2010 in Annals of Surgery showed that rate of mortality decreased from 45% in open to 24% in TEVAR. And also subsequent papers which has been published in Journal of Vascular Surgery showed that overall complication rates also were less in TEVAR. With this, there was guidelines suggested by Society of Vascular Surgeons. So they recommended TEVAR as the modality of choice, even in the ruptured descending thoracic aorta, whenever it is anatomically feasible. And this paper, which has been published in 2021, it has shown that only, this is with respect to the trauma setting, they assessed 71 cases. It was a retrospective study. So in that, they were able to see the significant decrease in the complication rate. However, owing to the low sample size, they were not able to statistically show there is improvement in the mortality rate. Although there were 4 deaths in open cases and there were no deaths in TEVAR 2. So with this, we managed this patient in a setting where angio was possible, and also the CTVS team was kept on hold, OT was kept on hold. So we both for this Raptor is an ideal situation where it is resuscitation with angiography and percutaneous techniques and operative repair. So in which both angio and open repair will be possible in the same OT setting, and it is the need of our for the similar patients. So coming to our experience with respect to the aortic injury, this was published in 2022 in Clinical and Experimental Emergency Medicine. We concluded that early suspicion and timely and precise diagnosis of the aortic injury is very important, as more than 90% of the patients can undergo early repair with TEVAR. And another paper which has been published in Indian Journal of Surgery in last year, in which we pulled last 10 years of data from 2010 to 2020 and 55 patients were included. We saw that grade 3 aortic injury was the predominant type, accounting to around 63% of the cases, and mortality was nearly 21% in these cases, which was comparable to the wire data. However, aortic specific mortality was less than 2%. And we concluded that endovascular repair is the preferred modality of treatment in patients who are stable. And also, we had an overall decreased rate of complication with respect to the open repair. So we had outcome that overall mortality and complication correlated with the hemodynamic stability of the patient and severity of other injuries and grade of the aortic injury. So what was the uniqueness of this case? First, with experience of managing near to 100 traumatic aortic injury cases, this was the first case where we saw progression from grade 3 aortic injury to grade 4 aortic injury. And apart from that, this case was complicated by a complete heart block. So our take-home message with this case is we should have high index of suspicion whenever patient comes with significant trauma, and precise diagnosis should be done. And as we can see in this case, all the case places wherever patient was transferred, it was infirm. So with respect to the available experience with us of managing to near to 100 cases and available facilities in our institution with multidisciplinary team management, we were able to successfully manage this case with damage control stenting, not surgery. Then fortunately, we were able to manage this case without any significant complications. So I would like to thank all the departments because of whose contribution we were able to successfully manage this. So TEVAR is a modality.
Again, sir, to begin, I reiterate with the acknowledgement to all the departments. Whenever we talk of trauma, it is always the teamwork which defines our outcome. And to say that, what we start with in a patient when we listen to the trauma, when we start with the emergency medicines, talk of the trauma radiology, because we can be only complete when the trauma radiology supplement with us, and we are thankful to Dr. Shiva and Dr. Atin are here also from the department, from the cardio radiology, because since these procedures are to be done at CN center, patients are being transferred, and in a trauma settings, what is important is the time and coordinations. So they are very helpful. Dr. Priya, Dr. Sanjeev, they're all the time. Whenever we talk, they are always there to help us and coordinate the timing of the intervention, what we are planning for. Second is the anesthesia team, the critical care. As well as we are talking about the damage control surgery, where in terms of what we say, the message is resuscitations and intervention, they go simultaneously. So it's one of the integral part, and then from the Department of Critical Care Anesthesia, I thank them. Madam are already here, and the CTVS do chip in where we need to have a standby, because most of the procedures which are there, they have to be on a standby. CTVS people, they are always ready there from their busy schedule all the time, and of course the transfusion medicine and the emergency medicine department. Thank you, and yeah, casualty in the sense, sorry. And I beg pardon if I miss somebody, and of course the residents who are all one of the pillars who take care of all the patients. Yeah, ma'am is here. Yeah, please. Because this case, when you talk about, most of the time when you see our experience, when you talk, because most of the patients, if they have a grade 4, they die at the scene. And majority those who say they remain one of the window which you talk about in the hemodialysis. If they are stable, then they can make it through. But these patients, when we graduated from the grade 3 to grade 4, and the ma'am will highlight more upon it. How it is.
I remember seeing this case. The first CT itself showed lot of hemothorax, and it was also percolating down. And I remember telling the resident, this patient is touch and go. So make sure that he is done as soon as possible. The only thing was it was a non-dated CT, so we asked for 2 or 3 sizes because it was a smaller kit. These patients usually are hemodynamically, so they are hypotensive. So usually we end up undersizing their aorta. So we tend to keep 2 or 3 sizes. And that is why on the day when he was scheduled, we thought we'll do a CT angiogram just to have, so that we don't end up with a smaller graft and already a small child who's expected to grow up. And we hope luckily had the lab ready with us, and within 10 minutes the patient could be shifted. And I remember doing this case with just 3 runs. Whatever he showed, that is all. We did only fluoroscopy. Obviously all the contrast was going into the into the pleural cavity only. So, and we were lucky, he's lucky that and thanks to all the, you have described the collaborating departments, all of us, we strive to do our best, and it is lucky when we end up with a case like this. Yeah. Thank you.
Yeah, sir, Narayan sir, please. Sir. No. One part we problem like the first thing everything that was seen, everything at that stage only yeah. That if there is a this is not damage, the patient has to observe in a high intensity care setting so that it can be done very quickly. Yeah, rightly pointed out. Sir. Yeah.
And that is why the patient was not done immediately.
Yeah, but just considering the first overall when you talk about, because whenever these patients been them in trauma centers, they are primarily hemodynamically stable. And if they are unstable because of aortic injuries, probably they will not reach to the hospital. One. Second, if they are unstable because of the associated injuries, because these are one of the variables which markers for the overall mortality of this patient. So we want that they get stable. That's why the moment they come, we are in contact with the radiology people that this is the patient, we are waiting for it. Whenever it becomes stable, we are planning for an emergent endovascular stenting.
Actually a contained.
Yeah, of course. It's a
He had already bled into the meridian and was actually
yeah. But the good part was the coordination in the team. And all the time, what we call in a trauma setting is the decisions are dynamic and based on the physiological. As far as if it's just physiologically stable at that point, right? The second the patient was taken into the OT, again stable, then they take a conscious decision. No, let us go for a stenting because it is easier, non-invasive. If you consider the open surgery, it takes time, and that's how it paid off. And we ultimately with a happy face on the patient's face. Thank you, and thank you again for all.